AO indications and outcomes.
Thanks for the introduction. Really honored to present. That was really interesting cases in that last talk. Won't be that interested in this talk, but I'll do my best. So I'm going to review acetabular retroversion and anteversion and review 3 associated cases. So my disclosures. So acetabular retroversion, we're all familiar with the radiographic signs: crossover, posterior wall deficiency, and ischial spine sign. So here's our case. This is a 16-year-old female that we evaluated for right hip pain. She's an active dancer. So she has all these classic findings of acetabular retroversion. She has an anterior wall that crosses lateral to the posterior wall with a crossover sign at the middle of the head. She has posterior wall deficiency where the posterior wall doesn't meet 50% of the femoral head. She also has an ischial spine sign that you can see on an AP pelvis x-ray. Another associated finding that you see in acetabular retroversion is that you see external rotation of the hemipelvis. So you almost see iliac view of the iliac wing lateral on the AP view, indicating that this is actually an external rotation of the hemipelvis that results in the retroversion of the acetabulum. So that's been described on CT scans. So you can measure a superior iliac wing angle, where you measure from the iliac wing to the anterior SI joint. And when we look at patients with retroversion versus control, you can see that about 40 degrees of external rotation versus 15 degrees in patients without retroversion, with significant variability that we see in external rotation of the hemipelvis, but this is what results in that retroversion deformity of the acetabulum. On the CT scan, we also measure acetabular retroversion at multiple levels, but specifically cranial and central. So these are the axial cuts of that 16-year-old that I presented. And you can see that she has retroversion cranially and low version with posterior wall deficiency centrally. In this study I presented previously in the retroversion series of patients, it was about 0 cranial with 16 in the control, and only reduced retroversion when you went centrally down into the acetabulum. There are published ranges for normal with acetabular version, both cranially and centrally, but typically central in the head, less than 10 degrees, is considered acetabular retroversion. But there is significant variability in how you do these cuts. So how does the patient position their pelvis with anterior or posterior tilt? That can affect those retroversion measurements. So you need to be careful about how the axial reconstructions are done when you're measuring acetabular retroversion on CT scan. So kind of highlights our need to find more sophisticated ways to measure coverage. We also use 3D reconstructions of our CT to look at focal deficiency. It's not really an objective measure, but just looking at the coverage of the femoral head. And you can see in her pelvis from the front, she has relatively, I think, normal anterior coverage, but you can see when we look at her pelvis posteriorly, she's got a focal posterior lateral deficiency. So with retroversion deformity, we see external rotation of the hemipelvis. This is an older study from the Mayo Clinic on top where they looked at what actually causes the crossover sign. And so they used pelvis models and augmented or resected the walls and got x-rays, and you can see that it's really the posterior deficiency of the acetabulum that results in the crossover sign that we see on an AP pelvis x-ray. And in combination with this, there's multiple previous studies that have looked at the volume of the acetabulum in patients with retroversion. So this is a study out of Utah where they show that actually patients with retroversion have a lower volume acetabulum compared to controls without dysplasia or retroversion. And there's a few other studies where they show that there's reduced acetabular volume in patients with retroversion, and also studies that show that patients with retroversion have similar acetabular volume to patients with normal version. So the problem that we see with retroversion is an externally rotated hemipelvis and a normal volume acetabulum. And that reflects the clinical outcomes that we see from Byrne, which is really extensively published. Their retroversion outcomes. So they did a change in practice study where they followed their patients who had surgical hip dislocation with rim trimming versus PAO, and they saw better longevity of, or more survival in the hips, longer survival in the hips that were treated with PAO with an anteverting osteotomy. So I think there's clear benefits to an anteverting osteotomy rather than rim trimming in these patients. So for these reasons, as our 16-year-old high school student with right hip pain, she's a dancer. We elected to treat this patient with an anteverting PAO. Show that. So we did an anteverting PAO, and you can see with the PAO, we're able to correct the crossover sign and also improve our posterior coverage. And we also combine our anteverting PAO with a hip arthroscopy. She had a significant cam deformity that was likely limiting her internal rotation also. So we did hip arthroscopy before the osteotomy to correct the cam deformity that you can see preoperatively and postoperatively that Robbie did. So then here she is, very early follow-up, 1 year, but she's got a good IHOT score, the corrected right side of her acetabular retroversion. So this is our case treated with PAO, if I can advance it. So alternatively, so we had our young female, posterior wall deficiency is our first case. This is a 20-year-old college football player that we evaluated in clinic and was eventually treated by Robbie. So you can see on the left, he has a crossover sign, large cam deformity. And then on our 3D reconstruction, you can see the rim fracture anterior laterally where he's impinging. So he has a low volume acetabulum with a rim impingement, large cam deformity. So for this patient, we elected to treat him arthroscopically. So you can see the pre-post. Here is Robbie doing the hip arthroscopy, demonstrating mobility in that rim fracture. So that rim fracture was resected with preservation of the labrum. So you can see the pre to post change in the crossover sign with that resected rim fracture and combining that with labrum tear repair. Also very important in this case would be correction of that large cam deformity. So you can see correction of that deformity here, before and after osteoplasty. And this patient also had a good outcome. You can see correction of the crossover sign. He returned to play his senior year of football 7 months. So 2 contrasting cases and managed differently. There is literature, a lot of clinical outcomes reported in patients with acetabular retroversion. This is a study that Robbie did of Chris Larson's patients. So looking retrospectively, comparing global retroversion to standard FAI cases, they found that males, as well as athletes and patients with femoral retroversion, had superior outcomes to females, non-athletes. Also, there's a systematic review that's been done by Ben Dome's group where they found both positive outcomes with both osteotomy and arthroscopy. But there are recent clinical studies looking at acetabular retroversion and how that affects outcomes. This first one's from Scott Martin in Boston, and they found lower survivorship at 8 years in patients that were treated for FAI with global acetabular retroversion. This is another interesting study from Shane No, where they looked at all their FAI surgery. They measured both acetabular and femoral version to see how that affected outcomes. And they found that patients with both low and high acetabular version had worse pain and disability pre-op as well as post-operatively. So there's definitely a contribution of acetabular version, both low and high, that negatively impacts outcomes of FAI surgery. So in summary of the retroversion section, there's definitely subgroups of hypermobility and femoral version that should impact our decision making when we're deciding whether to do PAO or hip arthroscopy for these patients. And I think we need better methods to regionally assess acetabular coverage. And I think global retroversion would really benefit from a observational multi-center consecutive study of sites that are doing both osteotomy and arthroscopy for these patients, similar to what's being done with the borderline group to look at outcomes in these patients. So. All right, and the opposite, acetabular anteversion or anterior undercoverage. A lot less discussion of this in the literature, but here's our case example. Robbie briefly presented it earlier, but this is our 20-year-old college volleyball player. She has a lateral center edge angle of 23, left hip pain. She has high internal rotation inflection. Hopefully that projects well enough for you guys to see. But here's a video of her playing volleyball. She's number 9, just got the block here. So you can see she's got a soft hip spica on that left hip. And watch, after she gets the block, she walks with an internally rotated knee progression angle and a neutral foot progression angle. So she has internal rotation at the knee with high femoral anteversion and external tibial torsion. Really struggling with hip pain, difficult participating in volleyball. So, more imaging on this patient. So she is a borderline dysplastic patient with cam deformity, anterior deficiency. She has high femoral anteversion. On CT study, we measured 35. Also, again, using that 3D reconstruction to look at anterior coverage of her femoral head. She clearly has an anterior deficiency. I think she's borderline based on lateral center edge angle, but I think more dysplastic based on her anterior under coverage. So for this patient, we have a patient with high femoral anteversion, potential hypermobility with borderline hip dysplasia and anterior under coverage. So this is a patient that we treat with PAO. So you can see here we did a PAO, being very careful not to overcorrect this borderline dysplastic hip and to improve her anterior coverage. We also combined this with a hip arthroscopy, given her cam deformity correction and also labrum tear at the same time as the PAO. So you can see improved anterior coverage and lateral coverage in this patient. Returned to volleyball 7 months post-op, 2 years. She's got a good Harris hip score and was able to finish her college volleyball career. So good outcome with this. No longer wearing that hip spica brace. So not a much less discussion of anterior under coverage compared to acetabular retroversion. I think the best work is being done by WashU, really looking three-dimensionally, not just lateral center edge angle, but coverage anteriorly and posteriorly in the acetabulum. And I think that's more of the work that needs to be done to look at these anterior under covered pelvises, or acetabulum. So future directions, we need 3D assessment of femoral head coverage. We need to incorporate both femoral version and tibial torsion into decision-making for these patients. Also looking at the functional position of the pelvis and how that affects hip mechanics dynamically. And I think that eventually we will be able to use computational techniques to measure contact stress within the joint to use as decision-making on how to manage both these anteriorly and posteriorly undercovered acetabular cases. So, thank you.